Riaz Mahmood and Hisham Qutob.
Hi, yes, my name is Samantha Schoenl, and I'm a fourth-year medical student at the Medical College of Georgia. And I'd like to thank Dr. Riaz Mahmood, who's the chief resident of the internal medicine program at Northeast Georgia, and Dr. Hisham Qutob, an intensivist also at Northeast Georgia, for their help in putting together this presentation. Next slide, please. So the objectives for this case are to illustrate an uncommon presentation of a common condition. So in this case, it's syncope, or the presentation of a myocardial infarction as syncope. And I want to review the foundational concepts of coronary artery anatomy, cardiac pacing, and the differential diagnoses of both syncope and sinus bradycardia. And we think that this case report is important because, to our knowledge, no cases have been published yet describing sinus nodal ischemia that presented as isolated syncope with preserved sinus nodal pacing. Next slide, please. So this case is a 70-year-old male who presented to the ED with a one-day history of multiple syncopal episodes and falls with traumatic injuries. On review systems was positive for fatigue, but it was negative for shortness of breath, chest pain, or any prior history of syncope. The past medical history in this patient was unknown. He lived in a very rural area and he hadn't sought medical care in over 10 years. Therefore, he was taking no medications. He presented with the vitals of heart rate in the 30s, a blood pressure of 76/55, normal respirations, and normal temperature. Labs included CBC and CMP in the ED, and they were within normal limits. And then the EKG obtained in the emergency department is pictured on the right. And you can see that it's sinus pacing, and the rate is in the 30s. The chest x-ray was negative for any cardiopulmonary process. CT brain without contrast was negative for any acute intracranial process, and CT maxillofacial showed bilateral nasal bone fractures and an anterior maxillary spinal fracture. Next slide, please. So in our differential diagnoses for syncope, we had vasovagal syncope high on our list, orthostatic hypotension, both due to dehydration or just due to age because of that depressed vestibulosympathetic reflex that occurs as patients age. We had thought of any autonomic insufficiency, but he showed no signs of Parkinson's or a multisystem atrophy, and then he wasn't taking any drugs, so that didn't make sense as a cause. Cardiac arrhythmias was also on the differential. This wasn't going to be a tachycardia because of the heart rate in the 30s. But for bradycardia, we thought of AV block or sixth sinus syndrome. The EKG was not supportive of it being an AV block. And then any structural cardiac disease was on the differential, like aortic stenosis, a hypertrophic cardiac myopathy, or an acute MI or ischemic cause. The physical exam findings did not support pulmonary embolism, neither did the vitals. And then it didn't seem like an acute aortic dissection, but we did consider that. Neural causes like a stroke or TIA were thought of. Stroke didn't really fit his picture. He had no focal deficits on exam, but potentially a TIA in which symptoms had resolved prior to his arrival at the ED. And then we considered non-thinkable causes like a seizure, psychogenic seizure, and then, of course, unknown cause. I did want to include this table on the right, which was taken from an article published in the New England Journal of Medicine that looked at the prevalence of different etiologies of syncope. And for the known causes, you can see that the #1 cause for both men and women is vasovagal syncope. And then the second most common cause for men was cardiac. And so those were kind of high on our differential at this point. So next slide, please. And then the differential diagnoses we were thinking about to explain his sinus bradycardia. So we thought of sinus node dysfunction as well as hypothyroidism. Again, medications was not a concern for him. We also thought of acute MI because those patients, 15 to 20% of them will have sinus bradycardia at some point in their clinical course. We also thought of obstructive sleep apnea. His picture didn't really fit for an increased intracranial pressure cause, and it didn't fit for the infectious causes that we thought about either. We also included genetic channelopathies on our differential. And next slide, please. So we repeated the EKG, and this is the rhythm strip on the right, but you can see the ST elevations, and the pattern was consistent with an RCA STEMI. The troponins had a 24-hour peak of 65,424, and so the patient underwent emergent coronary angiography, and it revealed proximal RCA to mid-RCA lesion with 100% stenosis, and he received export thrombectomy, and an RCA stent was placed successfully. Next slide, please. So here's some imaging from the angiography. Pre-stenting on the left, you can see that there's no blood flow through that distal RCA. And then after stenting on the right, you can see good blood flow. It was rated as a TIMI flow 2, and there was no evidence of any dissection or perforation from that procedure. And next slide. Thank you. And we wanted to review coronary artery anatomy with this case, and also intrinsic pacing rates of the conduction system. So first, for the coronary artery anatomy, the SA node is supplied by the sinus nodal artery, the SNA, and that arises from the right coronary artery in 55% of patients, and that's pictured in this lower left image of the SNA arising from that RCA to go and supply the SA node. And then it arises from the left circumflex artery coming off of the left coronary artery in about 45% of patients. And then on the right, this table is just nice because it illustrates the different pacing rates of the conduction system. So as a reminder, the SA node should be pacing 60 to 100 with the AV node 40 to 55, and then the His Purkinje system should pace 25 to 40. And our patient's presenting heart rate was in the 30s. So on a rate basis, it looked like more of a ventricular pacing picture. But when you look at the EKG, it's sinus rhythm. Okay, and the next slide. So this patient did well post-stenting. His hypotension resolved, and this was his repeat EKG, the last EKG that was obtained before his discharge. And you can see that it's normal sinus rhythm, and the rate is in the 60s, so it's back to normal. He was discharged on aspirin, Lipitor, Entresto, and aldactone. And then he was scheduled for cardiology follow-up in 2 weeks. He did not present to that appointment. And as of yet, at least at the Northeast Georgia Medical System, we don't have records to follow up. So I can't comment on how he's doing now. Next slide. So the discussion of this case. So in the setting of syncope with bradycardia and hypotension, we believe that neural causes and then myocardial infarction should remain pretty high on the differential. Also, we thought it was interesting to think about why this patient had hypotension with an MI that was affecting the SA node. And he was 70 years old. And so that atrial contraction as we age does account for about 50% of the end diastolic volume. And so we thought that was an interesting kind of clinical correlate for why you would have hypotension with a dysfunctioning SA node. And then this case raises the question of when is sinus bradycardia just sinus versus something that's pathologic and needs to be worked up? And then why was there a delay in this patient's conduction system switching from sinus pacing to atrioventricular pacing? And the explanation we kind of thought of is that this patient must have had a chronic course of this ischemia to the SA node, and he must have had the development of some sort of collateral vessels to sustain that SA node until he ended up having complete occlusion of the proximal to mid RCA on the day that he presented to the ED with those syncopal episodes. And in the bottom is a table comparing the rhythm strips for this patient throughout his hospitalization course. So again, the first one, you can just see that it's sinus pacing, but at that abnormal 30 beat per minute rate. You can see the ST elevations in the second row, and then in the third row, his return to normal sinus rhythm with a heart rate in the 60s. And next slide. And here's my references, and then that's the conclusion.
Thank you very much. Does anyone have any questions? It was a very good review of the pacing of the heart, so I appreciate that. Thank you very much.
Thank you for your time.